You are in a media conference for the release of our long-term care staffing survey. We have a few speakers. They're going to be very brief, and then we're going to have a question and answer period. When it comes time for question and answers, please flag us in the chat if you have a question. You don't have to put the question in the chat. Just let us know what media outlet you're from, and we will unmute you. This is a press conference, so questions are for the media. There is a link to the long-term care staffing survey in the chat there. And I'm going to introduce Natalie Mehra. She is the Executive Director of the Ontario Health Coalition.
Good morning. Thanks everyone for joining. We appreciate you being here. This is our first media conference by Zoom, so I'm hoping that it will work okay. And if there are any problems, if you could flag them in the chat, that would be great. So I'm just going to quickly review the results of the staffing survey for you. And then I'll turn it over to a few people who have hands-on experience in long-term care and work directly with staff in long-term care or in long-term care themselves to just talk with you briefly about what it's like right now in long-term care homes. And then we'll open it up for questions and answers. So staff describe the situation as heartbreaking. They say it's wrong. You can tell by the answers to their surveys that they're upset about what's going on. And anecdotally, since we all know that prior to COVID-19, there was a staffing crisis in long-term care, particularly among the PSWs, but also for RNs, also for physicians, frankly, and for other staff as well. But since the pandemic hit, more than 8,000 staff and residents have been infected by COVID-19 in long-term care homes in Ontario. More than 1,900 have died as a result of COVID-19. And more recently, we've heard media reports and we're hearing from staff about deaths due to dehydration and malnourishment in the homes. Anecdotally, we've been hearing from staff for weeks that things are worse than ever, that the staffing levels are worse than ever. And so we set out to find the evidence, find out what's really happening across Ontario. And so we put out surveys over the last week from July the 7th through, Friday, July the 10th through to Friday, July the 17th to ask, is staffing better, worse, or the same as it was prior to COVID-19? Are you working short-staffed? How short-staffed are you working? And what care, if you're working short-staffed, can't be done as a result? And so this is the result. We had more than 150 surveys returned to us from staff in more than 75 long-term care homes. They were a mix of for-profit, not-for-profit, and public homes, and the results are written in the survey, and they were from every region of Ontario. 95% of the staff report that they're working short-staffed. When we asked how often are they working short-staffed, 53% said every day or virtually every day. Another 10% said the majority of the time. 15% said 1 to 3 days per week. So fully 78% of the staff are working short-staffed multiple days per week to all the time. We asked if staffing levels were worse now than prior to COVID-19, and 63% said that they are worse now than prior to COVID-19. 28% said that they are the same. So fully more than 91% said that staffing levels are the same or worse than prior to COVID-19. Those results were worse in the for-profit homes. The majority of all of the homes obviously have worse staffing levels than prior to COVID-19. Worse in the for-profit homes, better in the fully public homes. That is not a surprise to us because as a general rule, I mean, some homes are different, but as a general rule, the for-profits have lower pay and worse working conditions, more casual staff and so on. And so we can see the differences. Staff report that they've worked without vacations, without stat holidays, without weekends off for months now during the pandemic. They've had time off denied. In many of the homes, they're reporting dozens of staff lines empty. That means there are no staff to fill those positions at all, and the entire shift all day, all night remains empty for those staff lines. Most of the homes report that when staff call in, they're unable to be replaced. And of course, call-ins are very high because people have not had any time off. When we asked what kind of care couldn't be done, the results were deeply disturbing. Most of the homes, more than 100 of the staff reported that baths can't be done. Their residents are regularly going without bathing and proper washing. Since it's not safe to lift residents on the hoist lifts without two staff, often staff can't do full baths because there just aren't enough of them to do it safely. They have to do bed baths if they have time for that, but they report that rushing care means that they can't do baths, and residents regularly miss baths. Emotional support was reported as almost non-existent. Staff haven't had time to explain COVID-19 to residents who are confused. They don't have time to visit with them. This really struck an emotional chord with staff who report that residents are lonely, they miss their families, they report that the residents are sad, that they're depressed, and yet staff have not had time to provide emotional care for them. Staff report that there is not time to provide appropriate palliative care. Activities of daily living, so that includes toothbrushing, putting on of creams, shaving, nail care, all of the personal care, they report there is no time to do it. Late and rush care is reported as happening all of the time in the homes. Cleaning is an issue that is reported as being undone. Staff can't tidy the rooms. They can't clean the residents' closets or their drawers. In the worst cases, bathrooms go uncleaned. There's a severe shortage of housekeeping staff, shortages of laundry staff, and that means that the laundry backs up. There aren't clean linens to provide for the residents when they soil their linens. More than 50 staff reported that feeding can't be done appropriately or on time, that feeding is rushed. It takes time to feed someone who is elderly and has dementia. People have to be cued to eat. Often they have to be reminded multiple times to eat more food. They have to be hydrated regularly in order to keep them from being malnourished and dehydrated. And staff report that very frequently there is not enough time even to feed and hydrate the residents. Repositioning, that means moving them so that they don't get bed sores. Staff report that frequently there is no time for repositioning or it happens late. Toileting, no time to toilet the residents when they need assistance going to the bathroom. And so the staff report that there are more falls because residents try and stand and do it on their own. And this is very distressing to residents. And the falls are obviously very dangerous. In a shocking number of homes, they report that there is no rehabilitation happening, no activities, no entertainment, less documentation or charting, no time to contact families or inadequate time to contact families and answer questions, late medications even, not enough staff to do medication carts, just overall a completely unacceptable level and quality of care. Which staffing classifications are short? Most commonly, they said PSWs, RPNs, RNs, but also housekeeping, dietary, and laundry staff, also rehab staff, environmental staff, activity staff, even management staff, porters. Many homes reported that all departments were short. The language that the staff described to use the shortages was shocking even to me, and I've been doing this for 20 years. In some homes, they're reporting that they're missing 60 of 155 staff. They're missing dozens of staff lines entirely. It's not just that no one is replacing staff that calls in, and that is dangerous in itself. They have dozens of just empty shift lines, empty positions that are not being filled, and it means that basic care can't happen. When they describe the care that can't happen, it is hair-raising. Basic care, feeding, the things that keep people alive, washing them, things that prevent skin breakdown, bed sores, these things are not being done on a regular basis in the majority of the homes that the staff work in that we surveyed. This was extremely distressing to us, and we have had many, many years of experience in this field. We're calling on the Ford government to take action now. We're expecting a second wave. the evidence points to a second wave of COVID-19. The long-term care homes in Ontario are not ready. They've already lost lots of staff because of illness, because they're afraid, because they were required to work in one place. And so they gave up the jobs that were more part-time or had fewer hours or worse working conditions, decimating the staffing levels in some of the homes. And they do not have enough staff to get through a second wave. We expect that more staff will leave if a second wave comes. In Quebec and British Columbia, governments have intervened actively. They've recruited more staff. They've improved the wages and working conditions. They have set out on big recruitment strategies to bring more staff in and get care levels up to safe levels. There is a deep consensus among all of the advocates, from families to residents to the expert advocates to the unions and health professionals, that we need a mandated minimum care standard of 4 hours of care per resident per day to keep them safe. And we're asking the Ford government to take as a priority action to deal with the staffing emergency in long-term care. It was a crisis before COVID-19. The conditions are unspeakable now. Action needs to be taken. The government has announced new long-term care homes. Who's going to staff those beds? There aren't enough staff for the existing beds in long-term care. This has to be a priority, and we're pushing for action as soon as possible. I'm going to turn you over to Shelley Smith. Shelley's worked as a PSW for more than 30 years. She now works directly representing PSWs in Southwestern Ontario. Shelley.
Oh, hello. Thank you, everyone. I just want to say, like, this is so repulsive, and I don't understand how this is allowed to happen. We are talking about people's loved ones. We're talking about PSWs who go to work every day, who feel obligated to try to provide the best care possible for these residents under these kind of circumstances. You've heard the conditions that they're working in. The homes are 90% short all the time. They work short every day, 4 or 5 shifts in one day shift. They're working short, numerous in afternoons, and as well as going into the midnight shift. Prior to COVID, this was an issue. We've had many, many conversations at the highest levels of the government, numerous lobbying sessions, countless reports, roundtable discussions, caring in crisis situation critical, and it's all fallen on deaf ears. It's fallen on deaf ears because what resolve do we have from it? We
Shelley,
have nothing.
Can
we
you
have
tell
nothing.
them how
We're
short
going
the homes are in your area?
Pardon?
Can you tell them how short the homes are that you're hearing in your, like, how many lines are left empty?
There are there are many homes with empty lines. One home that I know of in particular, they have 15 or more empty lines. Going into, as a result of the pandemic, some homes have lost quite a numerous amount of staff. One home in particular has lost 51 staff due to various reasons. As Natalie said, 40 of those staff were PSWs. So now we're going in, we know we're working short just to begin our day. Some staff are very tearful prior to going in because of the anxiety level. How am I going to accomplish my work today? The anxiety level is high because they worry about the consequences of not getting it all done. The baths are being missed. They have to try to give the best care they can with the number of people that they have, because time and bodies are not on their side. When we talk about staff working short, they work through their breaks, they work through their lunches to try to provide the best care they can with the staffing and the pandemic that we're in. Some of them go in a home that has no diagnosis of COVID. Staff are working, part-time staff are working 75 hours, full-time staff work 75 hours, but the overtime is 4 to 5 shifts in that 2-week period. So they're working 112 hours or more in a home that does not have any COVID in it. In a home that has COVID residents, those staff were working over 140 some hours in a pay period to provide care to these residents. They were working in conditions, not having proper protection, using whatever they have for PPE to try to provide care for these residents. This is not right. This is not acceptable. This is something that has been talked about, as I said, forever, and we need to have a resolve. We need to have a resolve moving forward, and we need to have a resolve before we hit the second wave, because when the second wave comes, your numbers are going to drop again. The anxiety levels of the staff are through the roof. You have to talk them off the ledges. They're fearful. They call me, and I can't help them because I don't know what to do for them. They want to go to work. They're fearful to go to work. They have to go to work because now they're the breadwinners. They're the only ones working. And at the end of the day, I had someone say to me, why is my life so undervalued?
Okay,
I don't
thank
have
you,
a
Shelley.
I don't
Thank you
have an
very
answer
much.
for that.
Thanks.
You know, it's you go to work, you do a task because this is what we love. We go in, we want to be able to take care of those residents the best way we can. And when you don't have the bodies, because the bodies are essential, the time is essential, how are you going to accomplish all this? The standards and the policies around how you have to provide that care doesn't allow you to get done even on a good day.
Thank you very much, Shelley. Thank you very, very much.
You're welcome, Natalie.
Okay, I'm going to turn it now to Joadel. Joadel has also worked in long-term care in hospitals. She's an RN. She contracted COVID-19 in her long-term care home and is recovering from COVID-19. Joadel.
Good morning, everyone. I'm going to give kudos to Shelley Smith. She's actually give a lot of experience and feedback and a lot of voices from the staff that are not able to raise their voices. I will just add into that that's the reality of our experience of our work. I know there's risk in our work, but having lying there on emerge and almost died, I don't want this to happen to anyone. September is coming. It's very scary. There's still not enough staff. I just had spoken to a lot of the staff or members, coworkers. Sorry, somebody's stopping. Anyway, managers were informed by the staff that they're still short in one of the floors that I work with. And they were informed by the managers that they're not short. But they explained again over and over that resident needs a lot of time to provide care. Our home was just outbreak free. It went back again to outbreak because one of the registered nurses are positive COVID. So we're back and forth, back and forth. So we really need to ensure that Mr. Ford hears us. And I hope that one day this doesn't happen to him, because I know we will get old and we expect that someone will treat us as what we are treating our loved ones or in the residents in our home.
Thank you, Joadel. And now I'm going to turn you to Lisa Burke. And Lisa works as a PSW currently in a long-term care home. Thanks for joining us, Lisa.
Hi. So my name is Lisa. I am a PSW in a long-term care home. We have been in a PSW crisis for a long time now, long before this global pandemic. I'm sure you've all heard of the 6-minute challenge, where you have to get out of bed, showered, dressed, your teeth brushed, your hair combed, and ready for your day in 6 minutes. Well, that's the length of time we have per resident on a good day, fully staffed. Now we are facing this pandemic where staff had to choose to work in one home. Most staff in long-term care work in multiple homes because they don't get enough hours at one job to support themselves and their families. So now we have multiple shifts empty because they had to choose one job over the other. Now we have even less time to do care. Staff routinely miss their breaks, their lunches. They're working doubles, they're working overtime just to try to fill the gaps and give the care, but we can't. Now with social distancing and safety procedures, residents have to wait longer to be fed. They have to wait longer to use the bathroom, often not getting there in time. Falls happen because there isn't enough staff to get to the safety checks in time. New admissions, who are often scared of entering in long-term care, are even more scared now. They're depressed and they're lonely because now they're isolated to their rooms for 14 days. Family can't come and reassure them and visit. We don't get enough time to sit and comfort them, listen and meet their emotional needs. Residents who are on repositioning schedules for wounds aren't getting repositioned fast enough because there isn't enough staff. Baths are getting pushed or switched to bed baths or sponge baths because we have no time or no staff, and there hasn't been staff for a very long time, way before this pandemic. It's unfortunate that it took a pandemic to show the world that long-term care has been neglected and overlooked for far too long. Now it's time for the government to step up to give long-term care what it needs, give PSWs staffing ratios to be able to meet residents' physical and emotional needs, a living wage so PSWs don't have to work multiple jobs to support themselves and their families, more hours and paid sick time so we don't have to choose between getting better or paying our bills. Now is the time to act, and now is the time for change.
Okay, so we're gonna go to questions and answers. Sala?
Yes, for everybody, please, if you have a question, please indicate in the chat that you have a question, and I will unmute you, and you'll be allowed to ask your questions.
Thank you very much. Lisa's joining us on a break from her long-term care home. That's why she's in her car. So Lisa, if you have to run, please, that's okay, okay? But stick around as long as you're able to safely. Okay, so we have Sue-Ann Levy.
Yeah, we have a question from Sue-Ann Levy. Just let me...
Here, I'm unmuting her. Hi, Sue-Ann, go ahead.
Hi, Natalie. I must say that jacket looks very nice with your eyes.
Aw,
On Zoom. I want to ask you, you've talked about all these problems and they're outrageous. So shouldn't this be the time that homes let essential family caregivers in to help you out? I mean, what is the problem?
Yeah, I mean, there's a mix. One is that obviously we're hearing from many families who it'll be the wife of a husband and for 40 years, you know, and she hasn't been able to get in, well, except for in the last few weeks, once a week for a 30-minute visit. You know, she hasn't been able to get in for the entire pandemic, and she used to feed her husband every single day in the home. It doesn't make sense that this is the way that they're running. It can't continue. There are problems because there aren't enough staff to deal with visitors, to screen them, to train them, to get them, you know, up to standard on PPE and infection control, to supervise the visits, to make sure that people are following those rules. Staff are terrified. Obviously, 8,000 people have been infected. I mean, they're terrified of this coming back. And so all of these conditions have to be balanced, but there is no way. This is not acceptable. It's inhumane. People can't be fed. If you can't, you know, if your husband has lost 35 pounds, as in the case of the person I'm talking about, then surely it's unbelievably inhumane not to be able to get in there and feed them. And so, yeah, it just doesn't make any sense. It is complicated though. I mean, we are hearing from families, hundreds of families. We're also hearing from the workers. I understand the complexity of it. The issue, though, is that they have to get staff into the homes, even to get the families into the homes safely. And so both things need to happen. And yeah, family add care, and they also take time. And so both of those things need to be recognized as well. But, you know, Sue-Ann, we completely support the call of the families to get back in. This is just, it's awful what's happening.
Can I just ask a follow-up? Wouldn't it be easier for the government just to supply people to train? I don't think it's that complicated because I have, you know, my parents, as you know, and we have certain rules and we do what we're asked to do, COVID tests. Wouldn't it be easier just to have people from the government or from the LINs or from the CCACs, God knows they have plenty of time on their hands, to go in and train, you know, admit people, and then that would be a tremendous help to homes and to all
Absolutely.
the people who are talking here today. There are creative solutions, don't you think?
Yeah, absolutely. And so, I mean, that system needs to be set up and it needs to happen immediately. We've heard from homes where family was let in and, with the best of intentions, took household cleaner and wiped down every surface that they saw in the home. Potentially, household cleaner is not strong enough to necessarily kill COVID-19, potentially infecting the whole home. So that just underlines that even with the best of intentions, ignorance about actual infection control is real. And there needs to be the proper training, and then they need to be supervised, right? So that things like that don't happen and endanger everyone by mistake. Fans don't get turned on and spread virus all over the place and those sorts of things. So yes, but I mean, that needs to be set up and it needs to happen, and it hasn't been.
Thank you.
Thank you, Sue Ann. Next, we have a question from Liz Payne from the Ottawa Citizen. Liz, I'm unmuting you now.
Thank you. I have two quick questions. One, I'm wondering what part of the province two of the workers or former workers who spoke are from.
Okay, yeah, so Joadel, can you tell them where you're from?
I'm from the long-term care that I work with, York Region area, Ontario.
Sorry, where? I didn't hear you.
What town?
Markham, York Region.
Okay, great.
The residents that work or the residents that reside?
That's fine. Yeah, you work in GTA area. Okay.
Oh, sorry. Sorry, Elizabeth.
Yeah. So my question was, what can be done, do you think, to improve the staffing situation in time
Wages.
For potential second wave?
The number one is wages.
And how do you mean? Like doing what they've done in BC, and what does that mean exactly in Ontario?
I'm not sure if you're aware right now, even the raise alone that Mr. Ford or the government, the 1%, there's not a lot of leeway. So the federal government offered, for example, I'm just citing my experience, okay? The federal government that offered the part-time members that had children at home that their immune system are low, the salary that they're making is way higher than the salary that they're going to earn working at our workplace.
You're talking about, you're talking about federal support. Okay, so what
the wages, basically, it's not enough. Their hourly rate is very low, and then they have to give up their other employment. There's still a lot of members complaining to the union that their hours are not even met. They have to give up their other employment. They're better off with CRB. So those are just examples. So those, in order for you to attract workers to apply or go back or rehire, because some of them quit, they have to attract through wages and benefits.
So, Shelley, you were telling me last night about the wages, for example, in some of the for-profit homes, that the top of the grid after 30 years was around, what, $22 an hour?
Around $22 an hour.
So that's after 30 years of work.
That's after 30 years of work, it's $22 an hour. And wages are a huge issue, but also the working conditions. Time, as I said, they need time to provide that care properly to the residents, and they need the bodies to do it. And they need to have a ratio of patient to staff care so that that can be accomplished. I mean, some of the ministry standards that are in place kind of are a double-edged sword in what you have to do to provide care to these residents. But I think the number one issue is to work the wages, the conditions of work. They need a ratio of patient to staff. They need time, and they need bodies. It's not acceptable for a for-profit owner to be able to lay off the very tool that I need, which is a body, for money, for profit.
Right.
Because
and Shelley, sorry, can I just give them a comparison? So you're telling me in the municipal, like the public homes,
yes,
the wage is what in comparison?
in the public homes or in the municipal homes, the the wage, I have a friend that works there, her wage is close to $30 an hour, if not $30 an hour. Their starting wage is 26.
So
Upon
when the
hire, it's
staff-
$26.
So I'm trying to eliminate when the staff were told they had to choose one home to work in, which was the right thing to do because obviously COVID was being transmitted from home to home to home. Then they would have chosen the place where they're making $7 an hour more, or where they can get full-time work. And that has decimated the staffing in some of the homes. There has to, the wages overall need to come up so that they're a decent level. But that's why you'll see in the report that the municipal homes are not as badly off, even though the majority of them are still working short staff. They're still not as badly off as the for-profit homes. And so, wages are definitely an issue. You can see that across the board, but also safety. People need to feel safe. Staff have left because they don't feel safe. They need proper PPE. That means N95 masks and not, the same residents transferred to hospital from long-term care homes are taken care of by nurses, paid, $10, $15, $20 an hour more with full PPE on, full PPE. The same resident, that left a long-term care home and has been admitted to hospital. That's not acceptable. Now we've had more than 8,000 people infected in the homes and more than 1,900 have died. So safety is key. The actual amount there needs to be a recruitment strategy like Quebec has done. We are short tens of thousands of PSWs. We're short nurses, we're short physicians, we're short the whole range of staff in long-term care. And so unless that happens soon, I don't know what will happen when the second wave comes. Sorry.
All right, now we have a question from Morgan Campbell. Morgan, you're unmuted now.
Great. I just wanted to ask, Ontario's allowing now 2 visitors per resident. Are there concerns that, with opening up these homes, allowing visitors in, that the virus could be, brought back in? And on the other hand, will that tie up staffing resources trying to facilitate those visits? Because we understand that, these individuals will have to wear PPE. I'm sure they won't be left on their own when they go into the homes. They'll likely have to be monitored.
That's the problem. I mean, the problem is balancing the fact that there is not enough care, that the families desperately want in because they know that every family that's called me says that their loved one has lost 20 pounds, 30 pounds in 4 months. I mean, it's very, very serious. So how can you not let them in when they're declining? They can see them declining emotionally, physically, in every way. And on the other hand, who's going to do this? Who's going to train them? Who's going to get them in? Who's going to provide all that? The government has been balancing that, I think, and there is a lot of pressure on both sides. And in our coalition, we work where there's consensus. We hear from the workers who are terrified, who know that there aren't enough staff. They want as a priority enough staff. The families agree completely that is the priority. And families also desperately want in because they see their loved ones declining. And unless there's policy intervention, like the homes, all through the pandemic, the homes have been left on their own to voluntarily staff up if they choose to access some small pools of money to do so, to voluntarily make agreements with hospitals by and large if they're going to get SWAT teams in. Only a handful of homes were taken over. Only a handful of homes had actual intervention. And now all of this is again being left voluntarily to the homes. Prior to COVID-19, they could not deal with this problem. They cannot deal with it now. They're even less resourced to deal with it now. The whole system has less capacity and resilience, and the individuals living in long-term care have less capacity and resilience to survive another wave.
And paint a bit of a picture. I don't know if this question is better served by Shelley or Joadel. Paint a picture. What does working short-staffed actually look like? How does it impact the staff members that are working on the floor that day and the residents?
Joadel,
Paint a real raw picture.
You want to go, Shelley, first?
You go ahead, Joadel. I'll chime in.
Okay, as a nurse, as an RN, I have a different role. Normally when in the morning when you come and they're short, you don't, while you're calling staff, that's my role. I have to try to replace staff because sometimes they don't answer because it's in early morning because I'm a day shift RN. If there's no one available, which that's the reality, you try to ensure that there's no showers. PSWs, you know, an hour and a half for 10. How can a PSW get ready at 10 residents? And those residents, my residents are like behavior dementia. We are in a lockdown unit. It's time consuming to redirect. It's time consuming to provide personal care. Sometimes they don't eat breakfast till 10. If it's you, do you want to eat breakfast at 10? Well, it depends on you if you're not an early riser. But most of us, we eat breakfast around 8, or for me, especially 6 o'clock, I have to eat. So, or drink my coffee at least to wake me up. So that's the reality. And it's not just now, it's just getting worse now. Some of my colleagues that are replacing me, because I've been off COVID from April 4. And then they had panic and anxiety attack in the med room, crying, sitting on the floor. We have our testimonials. It's very, very sad and very, very scared. Like until now, I'm scared. I'm still off work. I'm still wearing my Holter monitor. And every day I get texts from them and saying, you know, it's just getting worse.
And as for PSWs, I mean, they start their job at 6 o'clock in the morning, and they have 35 residents approximately to have to dress, prepare for breakfast, which is at 7:30, shower in that time. A lot of them are 2-person. The majority of them are 2-person. A lot of them have behaviors, which those those residents, you can't rush their care because it only adds to them being more aggressive or combative. And the end result there is that the PSW ends up injured, off of work, away from work again. So you try to prioritize, which is how do you prioritize when everything that you're doing for them is very crucial, but you try to prioritize your work. You bath who you can bath in that day. Not everybody's going to get a bath, but you have an hour and a half to get up 35 residents and try to get baths completed, try to provide morning care, brush their teeth, comb their hair, give them a shave before breakfast. It's impossible. And if you're down a body, it's impossible. If you're down 2 bodies, it's not going to happen. And so they prioritize the best they can by that bed bath or that shower may become a bed bath. The residents may go down with a robe on because they haven't got to them, or they may have to feed them up on the floor because now they're past their time for breakfast. It just keeps compiling the workload when you're short because you can't get it done. They have such anxiety, as Joelle said, because they worry about the consequences of not being able to complete all of that. A lot of them don't take breaks. You know, it's important to take a break because you need to de-stress yourself from the situation. A lot of them don't take breaks. A lot of them work through the breaks just to try to give that resident care.
Thanks.
They don't go home happy. A lot of them go home, they're upset. A lot of them, you know, I say, I've done the best I can do, but they know that's not the best that they can do. It's the best they can do in the situation. Pardon?
It has quite the toll on somebody, even outside of work.
It does, because, I mean, I can say for myself as a PSW, I go to work and I take care of the residents as I would want them to take care of my loved ones. And when you can't do that, you don't have a warm, fuzzy feeling at all. You
Thanks,
feel
Shelley.
very much like you've failed because
Thanks,
you had to give them, I always phrase it as a lick and a promise, instead of being able to give them that time that they deserve to have that proper bath and to have those conversations with them that just make them feel validated or for whatever. And through these situations, through the COVID and prior to COVID, none of that is happening, none of it. And, you know, when you just have a resident that wants you to just touch their shoulder or give them a hug or listen to the story that you've probably heard 20 times over and you can't, that is just as devastating as not being able to do the physical part.
Thank you, Shelley.
Next, we have a question from Steve Pakin. So I will be unmuting you shortly. You are now unmuted. Yep.
Very good. Thanks very much. Natalie, I would not want this question to be misinterpreted as in any way minimizing the very important testimony that we've heard this morning in this call. But I do note off the top that you said you heard from 75 long-term care homes in the responses that you got back, which is, I guess, a little over 10% of the entire long-term care home situation in the province. And if it's 150 responses you got, that's basically, 2 per home on average. So I guess I want to get a better understanding of how confident you are that you have a genuinely accurate picture of the overarching situation in the entire system. I know we've got a very good indication of the way things are amongst those who responded, but what about the system as a whole?
Yeah, well, through the pandemic, in the last 2 months alone, I'd say that I've spoken with more than 100 families, and probably at least the same number of staff. And in the 2 months before that, probably the same amount again. So we hear at the coalition from literally hundreds of people, and the stories are all the same. I mean, all the families will tell you about the weight that their loved ones have lost just in the last 4 months. It is routinely 20 pounds, 30 pounds. It's not hyperbole. We're not making it up. I mean, it really is, and I'm not offended at all. Thanks for the question, but it really is what we're hearing everywhere across Ontario, without exception. From the staff, same stories. I mean, the homes, we did 8 roundtables all across Ontario, 350, I think it was, more administrators, college administration staff, PSWs, union people, family councils, etc. And at that time, everywhere, every home, virtually every shift was working short. Now, the staff report everywhere that people have left. They've left because, of all of the reasons that we've given you, and things are worse. They're definitely worse. I feel very confident that this is a good indication of what is happening all across Ontario. I mean, that's not to take away, there are good homes and good managements and bad homes and bad managements, but there's a systemic issue here, which is that the workload has increased, the acuity has increased. That's indisputable. The workloads have increased. The actual staffing levels have gone down, even as the acuity has increased among the residents, and the pay just has not kept pace. And so we see the consequences. But after COVID, I mean, it's just much worse than it was.
Do you have a view, as a follow-up question here, do you have a view as to whether or not the new people hired into the system, which I presume everybody hopes happens, and the better wages that they get, do you have a view on whether those employees ought to be unionized or not?
Like, the coalition we don't have positions on that. I mean, we work with a number of unions. We work with a whole bunch of family councils and, people concerned about public health care. Obviously, in the homes where there are unions, there are better conditions. The unions have fought for better PPE and so on. So the coalition has never taken a position on that. I would imagine that our position would be that it is much better if they are unionized. And without the unions, really, we wouldn't have heard about what's going on in the homes, because all the staff are covered, almost all of them are covered by gag orders in their contracts. They're not allowed to speak out at all about what's going on. So it's very, very hard to get anybody who can speak safely about what's happening. I mean, at the beginning of the pandemic, one staff person that I know of put on her Facebook that she tested positive and was required to work. That's as per the directives that are still in place in healthcare. And she didn't name the name of her home. It was just her personal Facebook. She was fired for that. I mean, people are afraid to say anything because they know that they will be fired. So, do unions make a big difference in that? Yes, absolutely. Systemically and individually for people, and in terms of fighting for better conditions. In long-term care, the conditions of care are the conditions of work. They're one and the same. And so they have made a big difference, yes.
Thank you.
And the final question comes from 93.1, the Border Radio in Fort Francis. They asked me to ask the question on behalf of them. In Fort Francis, Confederation College and Riverside Healthcare, operator of long-term care, came up with an on-site program to fast-track PSW training to help address their shortages. Are you aware of any program elsewhere that can help with the shortage? And question 2 is, Northwestern Ontario has not seen the number of cases as in Southern Ontario homes. Any thoughts as to why, and can we learn from what's happening in Northern Ontario and apply that elsewhere?
Okay, so I don't know, have you guys heard of other fast track programs like that? I did see, I don't know, was that the Conestoga program that you were referring to, Salas? Sorry.
It doesn't mention, I don't know off the top of my head.
I just saw one on Facebook last night that people were commenting on. They were worried about it being 5 weeks. They were worried about, what training would be done and so on in it. But so I heard of a Conestoga program. Other than that, Shelley or Joadel, have you heard of any of these fast track training programs?
Let me interject first. It's just a Confederation College program.
Oh, just a normal program. Yeah. I mean, there are normal programs that are going on when schools are open.
Mm-hmm.
But a number of them last year had to be canceled because there weren't enough people seeking PSW training to run the programs. That was the problem. Anything to add, Joadel or Shelley, about that?
There is a support care attendant. That's the position that we are working right now with the management as a union side. So that's the only thing that I can think of.
Okay. I mean, I think what we need is a much more massive coordinated recruitment strategy like Quebec has done, where people are paid to be trained, where the government puts its weight and muscle behind the recruitment and the training, and people have access. The barriers are childcare. They're the cost of the programs, which can be $10,000. I mean, they're very expensive, some of them, and so on when they're running. And so all of those barriers need to be removed, and a big recruitment program, and then improving the conditions so that people actually want to do that work. In terms of Northwestern Ontario, yeah, across the north, there's just been far less incidents of COVID-19 from the very beginning. There were some cases, mostly travel related at the very beginning, and then just a handful really since then, comparatively. It's not totally clear why that is. So, I mean, there are just less people and more distances, I think, in some cases, but I mean, not being a virologist or epidemiologist, I can't really give you a concrete answer on why it has been so different in the north compared to Southern Ontario.
Yeah. I think if at the end of the day, we have to look at fixing the issues that are in long-term care in order to make it more appetizing for PSWs to want to work in it. I mean, we talked about wages, we talked about ratios, we need more full-time positions so that with benefits, so that PSWs are in one place of employment instead of 3 or 4 different places of employment. I mean, there's ample hours that could be given as full-time positions based on the acuity of the residents, the time, the challenges of the mentally challenged that are now coming into long-term care. I mean, we fixed some of those things, and it may be more appetizing for people. People are now making a living wage. They know that they're going to get full-time work. They know that some of their conditions of work are going to improve through this, and it may become somewhat more appealing to have people enroll into these courses.
Sala, how are we doing? Because do we have a long line of questions?
That was the last question that we had.
Okay. Thank you very much for joining us and for staying with us for all of this time. We really appreciate your attention and your concern about this issue. Thank you. Bye-bye now.
Bye-bye.
Thank you. Bye, everyone.